Pulmonary sequestration is an respiratory disease look at this lungs intralobular and extralobular sequestrations CT scan with contrast provide detailed imaging of lung sequestrations and vascular supply. MRI magnetic resonance imaging helps in visualizing abnormal lung tissue and blood supply. Doppler ultrasound identify systemic arterial supply to the sequestrated lung tissue. Then chest X-ray to identify abnormal lung masses. Look at this findings. A detail going on. Introduction. Pulmonary sequestration is a rare congenital lung disorder characterized by non-functional lung tissue that lacks normal communication with the tracheobronchial tree and receives its blood supply from an anomalous systemic artery. This condition can lead to recurrent infections, respiratory distress, and other complications if not treated promptly. Definition. Pulmonary sequestration is a congenital or acquired malformation in which a portion of lung tissue is not connected to the normal bronchial tree and receives its blood supply from the systemic circulation instead of the pulmonary arteries. Etymology. The term pulmonary sequestration comes from Latin roots pulmo lungs, sequestration to separate or set apart, referring to lung tissue that is isolated from normal bronchial and arterial connections. This congenital condition involves a non-functioning mass of lung tissue receiving blood supply abnormally from the systemic circulation. Types. Intralobar sequestration ILS. The abnormal lung tissue is located within a normal lobe and does not have its pleural covering. 2. Extralobar sequestration ALS. The sequestrated lungs tissue is entirely separate from normal lung tissue and has its own pleural covering. This form is often associated with congenital anomalies. Causes. The exact cause of pulmonary sequestration is not well understood, but it is believed to arise from an abnormality in lung development during embryogenesis. Some contributing factors may include 1. Abnormal embryologic lung bird development. 2. Defective bronchial branching. 3. Vascular anomalies. Risk factors 1. Congenital anomalies. 2. Family history of pulmonary malformation. 3. Premature birth. 4. Genetic predisposition. 5. Male gender. Higher incidence in some studies. Complications 1. Recurrent lung infections. 2. Chronic cough. 3. Respiratory distress. 4. Pulmonary hypertension. 5. Heart failure in severe cases. 6. Hemoptysis, cough up blood. Pathophysiology. Pulmonary sequestration occurs due to an abnormal development of lung tissue that lacks normal bronchial connections. The apparent lung tissue derives its blood supply from systemic circulation, usually from the thoracic or abdominal aorta. This results in an ineffective ventilation mechanism, leading to recurrent infections and respiratory issues. Pulmonary sequestration pathophysiology involves the abnormal formation and blood supply of non-functioning lung tissue. Here is a step-by-step breakdown. Step-by-step pathophysiology of pulmonary sequestration. 1. Embryological malformation. During early lung development, around 4 to 8 weeks of gestation, a portion of lung tissue fails to connect properly to the bronchial tree and pulmonary circulation. This leads to an isolated lung segment that does not participate in normal gas exchange. 2. Apparent blood supply formation. Instead of receiving blood from the pulmonary artery, the sequestrated lung tissue develops an abnormal blood supply from the aorta or other systemic arteries. This results in a high flow, low resistance vascular system within the sequestration. 3. Lack of branchial connection because the sequestrated lung tissue has no connection to the tracheobronchial tree. It cannot ventilate properly. Mucus accumulation occurs, predisposing it to recurrent infections and inflammations. 4. Chronic infections and inflammation. Stagnant secretions in the sequestrated lung tissue create an environment for bacterial growth, leading to recurrent pneumonia, abscess formation, or even fibrosis. 5. Complication due to hemodynamics. The systemic arterial supply to the sequestration causes a life to life shunt, increasing cardiac workload and sometimes leading to high output heart failure. Large sequestrations can compress adjacent lung structures, causing respiratory distress. 6. Clinical manifestation. Symptoms vary based on size and location, ranging from asymptomatic incidental findings to chronic cough, recurrent infections, hemoptysis, and respiratory distress in severe cases. Signs and symptoms. 1. Chronic or recurrent pneumonia. 2. Persistent cough. 3. Respiratory distress or difficulty breathing. 4. Chest pain. 5. Hemoptysis. 6. Failure to thrive in infants. 7. Cyanosis in severe cases. Diagnosis. 1. Chest X-ray identifies abnormal lung masses. 2. CT scan with contrast provide detailed imaging of lung structure and vascular supply. 3. Magnetic resonance imaging (MRI) helps in visualizing abnormal lung tissue and blood supply. 4. Doppler ultrasound identifies systemic arterial supply to the sequestrated lung tissue. 5. Bronchoscopy rule out communication with the normal bronchial tree. 6. Angiography confirms apparent arterial supply. Nursing diagnosis 1. Ineffective airway clearance related to recurrent lung infections. 2. Impaired gas exchange related to abnormal lung tissue function. 3. Risk for infection related to chronic pulmonary sequestration. 4. Anxiety related to difficulty in breathing and disease uncertainty. 5. Knowledge deficit related to pulmonary sequestration and its management. Medical management 1. Antibiotics to treat or prevent infections. 2. Oxygen therapy to manage hypoxia. 3. Surgical resection. The definitive treatment including lobectomy or segmentectomy to remove the affected tissue. Nursing management 1. Monitor respiratory status, regular assessment of oxygen saturation and breathe sounds. 2. Provide supplemental oxygen if necessary to maintain adequate oxygen levels. 3. Encourage coughing and deep breathing exercises to prevent lung infections. 4. Administer prescribed medications such as antibiotics and bronchodilators. 5. Educate the patient and family on disease process, treatment and post operative care. Treatment options A. Precision primary treatment 1. Lobectomy removal of lung lobe. 2. Segmentectomy removal of a lung segment. 3. Thoracoscopic minimally invasive or open surgery. B. Medical management 1. Antibiotics for infections. 2. Supportive oxygen therapy. 3. Bronchodilators if indicated. Psychosocial medicine 1. Patient education provide clear information about the disease and treatment options. 2. Counseling and emotional support addressing anxiety and fear associated with surgery. 3. Support groups connecting patients and families with others facing similar conditions. 4. Rehabilitation programs assisting with post surgical recovery and pulmonary rehabilitation. 5. Nutritional counseling ensuring proper nutrition for optimal healing and immune support. Prevention since pulmonary sequestration is a congenital condition. Prevention strategies mainly focus on early detection and management. 1. Prenatal diagnosis using fetal ultrasound to detect abnormalities. 2. Early postnatal screening for infants with recurrent infections or respiratory distress. 3. Timely surgical intervention to prevent complications. 4. Genetic counseling. If a family history of congenital lung malformation exists. In conclusion, pulmonary sequestration is a rare congenital lung disorder that can lead to significant respiratory issues. If left untreated, early diagnosis through imaging and prompt surgical intervention remains the mainstay of treatment. With appropriate management, the prognosis for patients undergoing surgical resection is excellent. Thank you. Have a nice day.